Let's go and we've got a couple intro slides and then I'll pass it over. So the Hip Hop Network operates in part on the current unceded traditional and ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh nations here in the lower mainland of British Columbia in Canada. We do invite all to reflect on the current traditional and ancestral territories, land, and waters, which allow us to work, live, and play. So we're happy to acknowledge that as we kick off this webinar, which will include people from all over the globe. Thank you, Tamara. And the next is just a quick disclaimer, of course, that the webinar reflects opinions, interpretations, insights of the people who are involved here. And of course, it's just intended as informational and educational. I'll let you read that. And we've got the recording as well, so people can participate now in person. And we look forward to well, I'll let Salil manage the questions and answers, how he wants to do that. If there's any input from the group, we have the chat open throughout, so we'll watch for that. And of course, the recording will be available after. Once we conclude, we'll get it posted and do some follow-up as well. So this will be available for folks who aren't able to join today. So thanks, Tamara. And yeah, so I'll kick this off by introducing Dr. Upasani. So he's a professor of clinical orthopedic surgery at the University of California, San Diego, and pediatric orthopedic surgeon at Rady Children's Hospital in San Diego. He's program director of the Pediatric Orthopedics and Scoliosis Clinical Fellowship and program director also of the 3D Innovations Lab at Rady Children's Hospital in San Diego. He's involved in a number of research pursuits, has received numerous research grants and awards from national and international organizations. He's an active member of POSNA, Pediatric Orthopedic Society of North America, as well as American Orthopedic Association, American Academy of Orthopedic Surgeons, Scoliosis Research Society, and is a charter pillar leader, executive member of our Hip Hop Network. And he currently is a co-lead of the community pillar, which is one of the 4 main pillars of the Hip Hop Network. And we're so proud to have him on our team. And so without anything further, I'll pass it over to you, Salil.
Great. Yeah. Thank you, Joel. Thank you for the introduction. Sorry, I just sent a request to share my screen. I guess, Tamara, you have to accept. Perfect. Thank you. All right, so it's my privilege to be here with this esteemed panel. Thank you so much for joining us, and for my co-moderators and speakers for putting together some excellent talks. I will be monitoring the question and answer, so we'll try to jump in between sessions, if that works for everybody. So I have Todd Blumberg here from Seattle Children's Hospital. We have Keith Baldwin from Children's Hospital of Philadelphia, Wendy Ramalingam from Cincinnati Children's Hospital, and Patrick Whitlock from Cedars Sinai Children's Hospital in Los Angeles. So the way this evening is going to work, each is going to give about a 15-minute talk, 10 to 15 minutes. We'll jump in with some questions and answers in between their presentations. And then we have some cases to go through and discuss. So look forward to all of your presentations. I will stop sharing. And Todd, if you want to get us started, thanks so much.
Great. All right. Well, thank you, Salil, for the introduction, and good evening or good morning, wherever you're joining from around the globe. And thanks for tuning in. I'll be covering the initial workup and management of the adolescent presenting with pelvic injury, as well as reviewing standard imaging workup and initial stabilization for these patients. It's important to remember that while many pelvic fractures in adolescents are high energy injuries, avulsion fractures are by and large still the most common adolescent pelvic fracture. However, these are not the focus of today's talk, and instead we'll be reviewing high-energy pelvic ring and acetabular fractures in adolescents. The approach to adolescent pelvic fractures should be multidisciplinary and systematic, as they can be devastating injuries and have a high potential for complications should these injuries be missed or diagnosis delayed. Pelvic fractures in children differ from those in adolescents and adults, however. By adolescence, the differences in physiology and mechanism of injury begin to actually fade, and fracture patterns begin to resemble those seen in adults. The likelihood of concomitant injuries is much more common, and the energy associated with pelvic fractures is significant, resulting in a high percentage of adolescent patients also having associated head trauma, abdominal, and reproductive organ injuries. The mechanism for the majority of traumatic pelvic fractures in adolescence occurs due to automobile versus pedestrian accidents or motor vehicle collisions. High energy sports such as football, rugby, examples like hockey as well, and bicycle and motorbike accidents round out the remainder of pelvic fractures that we see in adolescents and young adults. Initial inspection should focus on pelvic asymmetry, leg length discrepancies, and the soft tissues of the pelvis and perineum. Complete evaluation of the vagina, scrotum, and urethra is necessary to rule out urethral injuries and open fractures of the pelvis. Lacerations in the perineal region and significant ecchymosis over the pelvis should raise suspicion of an intrapelvic injury. Morel-Lavalley lesions are internal degloving injuries and involve a shearing of the subcutaneous fat and skin from underlying fascia, and a classic indicator of a high energy mechanism that should alert you to potential pelvic injury as well. After the initial inspection of the patient, palpation to assess stability is performed. Instability in the pelvis can often be appreciated by applying posteriorly directed forces on the anterior iliac crests, and rotational stability can be assessed by applying force on the external ilium, rotating the pelvis inward and directing it towards midline, aiding in the identification of pelvic instability that would benefit from rapid stabilization. In the setting of any gross instability on palpation, a binder or pelvic sheet placement is critical to provide a tamponade effect and can certainly be life-saving in these patients. Sheet placement is done by placing the sheet centrally over the greater trochanters, crossing the ends of the sheet across the pelvis, and pulling them tight to apply gentle inward pressure, securing them with clamps to hold the sheet in place. Sheeting a pelvis is a temporary measure to stabilize a potentially life-threatening injury. This example shows the incredible volume reduction inherent to sheeting an open book pelvic injury with symphyseal disruption. This can quickly stabilize the patient with hemodynamic instability and permit further workup. Sheeting is indicated in any patient with a grossly unstable pelvis on clinical exam, or those with visible symphyseal widening or diastasis on X-ray or plain imaging. I would also encourage using in-the-field binders or sheeting techniques in the setting of a patient who has blunt force trauma and hemodynamic instability. While it's not always known if they necessarily have a pelvic fracture at that point, there's truly almost no harm in placing a sheet or binder, and the potential benefits, especially for a patient who may have hemodynamic instability, are quite significant. After stabilization, further workup for those with pelvic fractures should include a careful neurovascular exam with extra attention to circulation and the motor exam of the lower extremities. High energy injuries may result in neuropraxia, and significant bleeding in the pelvis can cause compressive neuropathies affecting the lumbosacral plexus. After initial evaluation and assessment, plain radiographs are indicated with any high energy trauma. Many centers utilize an AP pelvis X-ray as part of their formal trauma series. Additional oblique views are critical in the identification and management of any pelvic injuries, including iliac and obturator obliques, which are obtained at a 45-degree angle away from midline, and inlet and outlet views, which are obtained at a 30-degree cranial or caudal trajectory to evaluate the pelvic ring. These images can often be reconstructed nowadays after a CT scan, and certainly can be deferred on initial workup depending on your institutional protocols. CT scans are essential in the setting of pelvic ring and acetabular fractures and provide a more thorough understanding of the fracture pattern. This AP pelvis image was reconstructed from a CT scan of a patient with a high energy acetabular fracture. Two additional views shown here can be also reconstructed when there's concern for pelvic ring injury. This is a 30-degree oblique or inlet view demonstrating much better posterior pelvic ring structures, as well as a 30-degree cranial tilt or the outlet view, which will evaluate the anterior pelvic ring and assess vertical stability of the pelvis much better. Because of the complex anatomy of the pelvis, acetabular fractures are best visualized on 45-degree oblique views, which provide nice direct assessment for the anterior and posterior columns and anterior and posterior walls. These views are obtained by either placing the patient under a foam wedge with providing tilt to the pelvis for the beam, or can be done by rotating the beam 45 degrees relative to the patient. Alternatively, as demonstrated earlier, these can nicely be reconstructed from your center's CT scan that was done. Iliac oblique view shows the posterior column really nicely in profile, as well as the iliac wing and anterior wall, while the obturator oblique view is going to place the anterior column in profile and show the obturator foramen and posterior wall. Sacral fractures and injuries to the SI joint are easily missed with plain radiographs, so these are going to require CT scan for further evaluation. While many pelvic injuries may be obvious, I want to draw your attention to a unique challenge in the adolescent population specifically. The hips of younger children and adolescents can dislocate from lower energy trauma due to the laxity of the capsular ligamentous structures, as well as high proportion of cartilage in the acetabular rim. And certainly dysplastic patients are at higher risk. One study identified nearly a third of patients between ages of 11 and 15 had a osteochondral injury associated with a hip dislocation. Given the relatively high incidence of associated injuries in the case of known or suspected hip dislocation, advanced imaging is required in these patients. For those who had a known hip dislocation event, 3D imaging is critical to assess for any associated osteochondral fragments that may be intra-articular after a closed reduction. While there can be some subtle findings on X-ray, including asymmetry and femoral head lateralization, these fragments may be wholly cartilaginous and only visible on an MRI. Since it can be difficult to obtain an MRI in the acute setting, it is often contraindicated in an unstable patient. A CT immediately post-reduction could certainly be obtained with plans to obtain an MRI once the patient has stabilized. For this patient, plain films were unfortunately interpreted as normal. However, advanced imaging was obtained given the high energy motorbike mechanism that they had, and they had significant left hip pain with an inability to bear weight as well, suggesting perhaps more was going on. CT scan, as you could see earlier, revealed an osteochondral fragment in the joint, and an MRI confirmed very large hip joint effusion, disruption of the posterior capsule and labrum, suggesting that there was a transient hip dislocation that reduced before the patient presented to the emergency department. To highlight the importance of having a high index of suspicion for these injuries, here's another case with a patient who presented after they were tackled playing football, unable to bear weight. Their initial images were interpreted as no acute fracture, but in hindsight, these images certainly suggest there may have been more going on, including recognition of the fact that there's lateralization and widening of the medial joint space on the left side, and in a patient with comorbid hip dysplasia as well. 12 months after injury, the hip had developed significant arthrosis and degenerative changes and was subluxated by the time they presented to our clinic, suggesting that if this perhaps had been identified earlier, we might have been able to prevent this complication. Here's their advanced imaging with an MR arthrogram confirming intra-articular loose osteochondral fragment and significant joint damage at this point. So this case really highlights the need to have a high index of suspicion, and certainly the importance of obtaining critical imaging, not just critical evaluation, not just of their plain films, but having a very low threshold to obtain 3D imaging studies to avoid this complication. That concludes my introduction to our discussion. I'll pass the baton off.
Yeah, thanks, Todd. Excellent introduction. Thanks for getting us going. I love the fact that you showed those 3D reconstructions with the oblique orientations as well as the inlet-outlet views. I wanted to get a quick, poll of our panel. Are we still getting all the plain X-rays? Obviously, that's what we're going to use in the postoperative period. But in the initial evaluation, is a quick CT with these reconstructions adequate? What are people's thoughts on that?
I'm not pushing to get the entire series anymore if we're able to get a CT relatively quickly or even an MRI.
Perfect. Yeah, I'm leaning towards that as well, especially with our low dose CT. We're getting it to about, 3 AP pelvis exposures. So instead of the series of 5 and then getting the CT, I don't think we're getting any additional information from the plain radiographs. Todd, do you agree?
Completely agree, 100%. Yeah. I think that's pretty standard now, I think, for most institutions that I've been in discussion with.
Great.
Thanks, yeah, we get post-reduction CTs usually.
Yeah. Oh, okay. So not pre on the initial eval. So plain AP pelvis X-ray. If there's a dislocation, you're going to reduce and then get a CT.
Yeah, I mean, usually most of them come to us pre-packaged with X-rays. Mm-hmm. Some of them will come with a CT, but most of them will come with X-rays. Like, I mean, you're referring to like a dislocated X-ray.
Yeah, right. Or just a pelvic, like a ring an open pelvis injury, and if it were, Yeah, exactly. Is it worth getting all 5 views, inlet, outlet?
Oh, no, definitely CT for that.
Yeah. All right, great, Keith. So you want to talk to us about hip dislocations and femoral head fractures?
Yeah, I
please?
think so. Can everybody see my slides there, or
Yeah, just share, turn it to,
play from start? Yeah.
yep. Great.
So I'll be talking about pediatric hip and dislocation and femoral head fractures. I'm Keith Baldwin. I'm the director of orthopedic trauma at CHOP. So I'm a consultant for orthopediatrics, but my consultancy has nothing to do with this topic, and I won't be discussing implants, so it's not really relevant. So basically, in this talk, hopefully, we'll identify key questions regarding traumatic pediatric hip dislocations. Hopefully, be able to generate a treatment plan for a traumatic hip dislocation, and understand key knowledge gaps in pediatric hip dislocation. So basically, there's this thing called this might seems like it's coming from totally out in left field, but basically, there's this idea of the Yerkes-Dodson law. So there's an ideal area where you want to be stressed in order to perform adequately. So if you're too non-stressed, you'll be bored, and if you're too stressed, you won't do a good job because you'll be too nervous. So you ideally like to be in this zone where you're perfectly stressed out. And so, most of our careers, like we do these big cases, we kind of know what we're doing. There's some, the case might throw us a curveball, but we're kind of in that optimal sort of area of stress. However, in some cases, there's pathologies that cause stress, and hip dislocations and femoral head fractures tend to be one of those things because it's an unfamiliar pathology. Hip dislocation only happens in like 0.8 per million children, so it's a very, very unusual pathology. And in those children, femoral head fractures are 2 to 3% of those. So it's like very, very unusual to have that. So all these cases are like unicorns almost. There's an unclear outcome because there's about 24 studies of these, but they all have 6 to 47 patients. All of them are non-comparative. And so it's a little unclear, what to do. It's an acute issue, so there's really no time to plan. You have to kind of just come up with a plan on the fly. And bad outcomes are possible. There's an 11.4% rate of AVN. You can get osteoarthritis, chronic pain, hip instability. So the idea is to shift us towards this sort of happy zone by understanding a little bit more about the pathology. So I recognize these are adolescents. I picked a 5-year-old, so maybe that's wrong. I don't know. But this comes up all the time. So this 5-year-old's at an outside hospital, and the questions going through your mind when you're on call are, do you reduce it there? Do you transfer and reduce? Do you do it in the OR? Do you do it in the ED? Do you let a trainee do it? Or do you just do it yourself? What's the timing of it? And what's a preferred imaging modality that you do afterwards? So as far as data goes, Chuck Melman did a study that showed that like 6 hours or less decreases the rate of AVN. So if you get it in 6 hours or less, it's good. But some of these other ancillary questions like who does it, where is it done, what level does it, is largely dictated by timing. There's not really any data, associated with it. You would think, hopefully, in a perfect world, a higher level of care would result in a lower chance of injuring something that doesn't come in injured, i.e., like a physeal fracture or something like that. But also, it costs you more delay, and can you afford it? Is the whole question. So, like, my preferred technique is basically you want to get it in under 6 hours. So you want to know like when the injury occurred. Does the outside hospital have the capacity to safely reduce it? How long will it take to get to the hospital, sedate, reduce? Is it easier to transfer directly to the OR? These are the questions that you should be thinking about. In my hospital, transfer is relatively rapid. The ED is responsible, sedation's available, and the OR can kind of be less predictable because there might be other cases going on. So in most cases, I usually will have it transferred to RED, reduce in the ER by the resident, and just let the OR know so it can be converted rapidly if it needs to. But it's kind of unusual. Most of the time they'll get it in. And my rationale is basically like AVN is more common than physeal fracture. AVN is 11.1%, whereas physeal fracture is like less than 3%. So my thought is that it's better to try to get it in sooner. And because of the indication that delay increases the rate of AVN. So therefore, we should be trying to minimize delay, I feel. Imaging and relaxation are desirable, but shouldn't increase delay because your goal is a gentle, pain-free reduction maneuver. So how can you differentiate these? So most of them are posterior, and it'll be sort of high and lateral. The leg appears short and internally rotated. In the unusual case that it's an anterior or an anterior-inferior dislocation, for anterior, the head's medial and it looks sort of bigger than the other head, and the leg won't flex because it's blocked. In terms of an anterior-inferior dislocation, those are even more unusual, but the leg will be sort of obligately flexed, and it'll be low and medial, and the shaft will point up. The shaft of the femur will point up. So how do you put it back in? So the most common way it's out is posterior. So all the ways that there's like a million different like techniques described to put it back in, but mainly it's you want to flex the hip up to 90 degrees, traction while you're adducting with a little bit of internal rotation, counter pressure on the pelvis, and then you abduct and externally rotate and then extend. And you want to have an abduction wedge or brace available for after. You don't want to do too forceful rotation because that's where you're going to get a fracture. So there's lots of different reduction techniques. This is like a sort of a partial list of all of them. My favorite one is the Captain Morgan because it looks the coolest, but you can really do any of them. I usually just sort of stand over and pull up straight, and then sort of adduct a little bit and then abduct. And that usually works out just fine. And that's kind of your more standard Alice, you can see the proper body mechanics. That's usually me. So anyway, anterior dislocations are a little less common. I've never actually had to reduce one, but you pull in straight inline traction with usually it's helpful if you kind of have somebody pulling on the inside of the thigh because the head is medial, so it's helpful to pull it out there. And remember, you can't flex it up because it's blocked. So obturator is also very, very rare, and you're going to use flexion, adduction, and an external rotation for that. So the next thing is, hooray, it's in. So what do you do then? So there's questions about post-reduction imaging, post-op immobilization protocol, what your exam needs to be, what kind of follow-up, what kind of return to sports. And the great thing is there's no data, so you can do whatever you want. But in terms of imaging, this is the most key thing, right? So MRIs are generally preferred because of there's a lot of cartilage. You're going to miss a lot of, just purely cartilaginous issues with a CT. But it's really hard to get in a pinch. It's better for soft tissue, better for cartilage. There's no radiation, and it's usually worse for bone. I put a star there because you can get a sequence that looks like a CT with an MRI, and our institution will do that. So it's not always worse for bone at CHOP. CT, it's better for bony injury. You can gauge if the reduction's concentric, so that's why we like to get those right away because they're easier to get. There is an issue with radiation. Obviously, it's a lot more radiation, but it is much easier to get. And in this case, it's usually worth the radiation. So for kids specifically, I think CT is probably okay if there's an acute concern or suspicion for residual instability or in skeletal maturity, or if you just can't get an MRI, quickly. In cases of open triradiate cartilage, the posterior wall may not be ossified, and CT will underestimate injury to the structure. For younger children, post-reduction MRI is preferable if it can be obtained. And even if you get a CT, it's probably good to get an MRI in younger kids. Klingel from Nationwide wrote this paper on this flex sign. It's a capsulolabral avulsion of the posterior labrum after dislocation. It's a form of what we call a trash lesion, or the radiographic appearance seemed harmless. And basically it's like it's a bigger piece than it looks like, more damage than it looks like, and so you should look into it a little bit more. They described actually ways in which they fix it in a separate paper, and the issue is that it can potentially lead to deficiency of the posterior wall or micro or macro instability. So if it's in and stable, what's the protocol? This is the most common scenario that we see. In our center, most were immobilized for 2 to 6 weeks with an abduction brace. And most of them, over 80%, were either non-weight bearing or toe touch weight bearing. However, there's no data on this. So suppose it won't reduce. So open reduction considerations, you have to think about the direction of the dislocation, what else needs to be done, what else needs to be fixed. There's obviously further AVN risk, particularly if you're going posterior. But in general, femoral head fractures, neck fractures, anterior acetabulum fractures, anterior approaches are usually better, assuming that the dislocation was anterior. Posterior wall fractures, posterior capsule, obviously a posterior approach is better for that. Lots of people on this call do surgical hip dislocations. They're great. I mean, it's safer for the vessels. There's more exposure for femoral head fractures or interarticular work. So final thoughts, there's currently more questions than answers on this. There's lots of small series with incomplete data. So we need large multi-center studies to answer key questions regarding the management of this entity.
Awesome. Thank you, Keith. So, after you pop the hip in, I feel like the CTs underestimate the damage and MRIs overestimate, right? It's almost like too sensitive. The entire posterior stuff is blown apart. There's a ton of edema. Do you find any value in a stress exam, or do you guys do any stress testing after the reduction?
We don't, but maybe we should. I mean, we had this one kid who came in with bilateral dislocations.
Mm-hmm.
And one was stable, and then the other, after we got follow-up X-rays, was out again. And after having been in on CT, so that case would have been helped, or we would have at least known that there was an issue if we had done a stress exam. So I think there's definitely a role for it. I guess like in a perfect world, you would do these cases all in the OR, and you would do like fluoro exams and kind of know like what you were dealing with better. And maybe that's the right answer. It's just like I said, these are so unusual that it comes in, you're kind of like, what do we do? Maybe that's what I'll do next time is do it in the OR,
Bring them to
if
the
it's
OR.
available. Because like in a big center, I'm sure this happens at Rady also. Like, there could be like a liver transplant going or something, and then you're not getting in there unless it's like,
Yeah, it's hard to get that. It's hard to get the timing right. Wendy, what are your indications? If you see that flex sign on a CT, when do you take them to do a repair? Or how do you decide who needs surgical treatment?
I think if you see the flex line, I'm probably getting an MRI too, and seeing how big the piece is to decide if there was a dislocation. Like it's already proven that it's unstable. So I don't know that like if you have a fracture and you have like a documented instability that you need to do necessarily a stress exam, unless you really want to like make sure that it's not like going to go out again. But I just look at the size of the piece and try to decide based on that, like how big of the joint surface it is, how separated it is.
Okay, yeah.
I usually look at them I used to look at them with Patrick, but he left us, so.
Nice. All right, so Wendy's going to speak to us about pelvic ring injuries next. I'm going to share your screen. And you're muted.
All right, I can do this. All right, guys.
Perfect, thank you.
So thanks for having me. I'm at Cincinnati Children's, like Salil said earlier, and we're going to talk about the surgical techniques for pelvic ring injuries and open fractures, which is kind of a broad topic. So we should be able to get through it. We'll start with a consult. This is a 9-year-old, could be any 10, 11, 12-year-old either, but dirt bike injury, hemodynamically stable in the emergency room. These are the x-rays that he has come in with. And so we can see that there's some anterior ring disruption in the right obturator ring. It looks like it's vertically displaced compared to the left side. And there's something going on in the back. There's some widening of the SI joint, and maybe there's a fleck of apophysis in the back. This kid came in early in my career, so I did get completion imaging on everybody when they came to the emergency room, first couple of years of practice. But so we have the inlet and outlet views that also show some displacement. And I knew there was something going on in the posterior ring, but it was hard for me to tell on these images what exactly was going on. And so questions like we just talked about, do you get a CT? Do you get an MRI? Where do you go? And so in this situation, we got, I did get a CT. And I think it is helpful to get CTs in the emergency room because it's much faster than getting MRIs, especially where we are. And so it will help you identify complex injury patterns, look for displacement, look for significant ring disruption, and also helps with preoperative planning. And so this kid did get a CT. And on his CT scan, the posterior ring had an apophyseal chondroosseous separation at the SI joint, where the iliac apophysis separated posteriorly from the iliac wing, and the iliac wing dislocated posteriorly. And so the posterior SI joint ligaments were intact, but the anterior ones were not intact. And so when you're classifying these fractures, as you get into the more adolescent age group with the older kids, you can use the typical adult injury classifications, like the Young Burgess classification, which is usually what I use. But for pediatric patients, if they have open triradiates and open apophyses, you can use the Todd classification. And then there are, I think, pediatric specific fracture patterns that should be appreciated. You can have single bone injuries due to the the nature of the pelvis with being more elastic and having a thicker periosteum. You can have iliac wing fractures that are incomplete, or buccal fractures and isolated, or you can get what this kid had in the back, which is an apophyseal chondroosseous separation at the SI joint. You can also get those in the symphysis as well. And so this kiddo, And so for treatment, most of these fractures, like Todd already said, can be treated without surgery. And so any of those type 1, type 2 fractures, and most type 3 fractures that don't really have significant displacement or instability can be treated non-operatively. And we've done that in a variety of ways over the years, but typically you want to mobilize your patients. And so I'll make them either toe touch weight bearing or allow them to weight bear as tolerated. And I will routinely get post-mobilization x-rays on these kids to make sure that once they mobilize with PT before they leave the hospital, that they're able to mobilize because their pain will allow. And then secondly, I'll see them back pretty early just to make sure everything stays put once they leave the hospital for more of the, not necessarily single bone injuries, but more of the, anterior and posterior injuries that don't look that bad. And then you can usually progress kids to weight bearing earlier than you can in adults because they're pretty quick to heal. And so looking at pelvic ring injuries, deciding which ones need surgery, clearly open fractures will need to be taken to the OR. They've proven that they're unstable enough to cause an open injury usually. And then anything with significant displacement during weight bearing, or the patients, like sometimes they'll be too painful to mobilize, which can indicate that they have a lot of instability. And then looking at the more severe anterior and posterior ring disruptions, pelvic asymmetry is a good measure for deformity of the pelvis. And that can be used to determine if you need to fix them or not fix them. And then anything that's unstable should go. And so in this case, if you're really not sure if they need to be fixed or not fixed, you can take them to the OR to stress them. And so Claude Saji has a great paper that describes, like 9 different x-rays that you take in the OR to stress the pelvis in different ways to see if it's going to displace or not. And if it displaces, you're already there and you can fix it. So when deciding how you're going to fix these, I think it's helpful to split the injuries into the anterior and posterior rings to decide like which methods you need for the specific fractures that you have. In the front of the ring, you can either do an open reduction internal fixation with plates and screws, or you can do an X-fix. It's just important in these scoliomature immature patients to remember that the symphysis has apophyses bilaterally. So you want to avoid damaging those if possible during ORIF. And then once the patients, if they still have growth remaining, you would want to remove their hardware once everything's healed up. And then typically I only do an open reduction and plating if I can't use an X-fix, or there's a reason I don't want to use an X-fix, or if it's especially in younger patients, because I don't necessarily want to have to go back and take out the plate. And so you can do either super acetabular pins or iliac crest pins for your X-fix if you're going to go that route. Biomechanically superior or biomechanical studies have shown super acetabular pins are more superior than the iliac pins. But both of these will violate an apophysis and can cause potential growth disturbance in those areas. But neither of these places, I think, matter that much for placement of the X-fix, as long as you don't go into the triradiates. And then for the posterior ring, for any of these displaced unstable fractures, Ideally, you can hopefully get them reduced under closed methods. And that way you can do percutaneous screws, and get your preoperative CT is very helpful in these situations to determine where your screws will go. And so the study looked at a bunch of patients under the age of 16 to see where they had safe pathways for a screw, which was essentially like a 7 millimeter kind of cube or rectangle. And so most patients that are scaly mature have a safe corridor for an S1 iliosacral screw, but only about half of them have a safe corridor for a transsacral transiliac screw at that level. So just important to remember that as you're looking for where your screws are going to go. And then if you have an O-arm, if you have navigation available, it can be helpful for screw placement for SI screws. And then determining what size screw you want. Usually we'll use like a 6.5 millimeter screw, cannulated screw for adolescents. But if they have a small pelvis for whatever reason, you can use smaller screws. And then typically I'll take out SI screws after about 4 to 6 months to prevent bony overgrowth and deformity. So if you need to open reduce, you can do the lateral window for the ilioinguinal approach. You can do the whole ilioinguinal approach, I guess, if you need to, but just using the lateral window will get you back to the sacrum in the front. And then the posterior approach can be useful if going anteriorly is not possible, or if you have a sacral fracture that you need to reduce, you'll probably be going from behind. And so just to touch on open fractures of the pelvis, like any open fracture, time to antibiotics is key, which is determined by whether or not you recognize that it's actually an open fracture. And so these injuries can be hidden. And so you do need to do a really good exam initially to look for internal bleeding in the GI or GU tract, and then wash everything out, get them their antibiotics, and decide if you need to alter your surgical plans based on the fact that there was an open fracture. You may be less inclined to put on a plate in the front of the pelvis if there was an open injury that was contaminated. So back to our patient, we had our separate injuries. We have the superior and inferior ramus fractures in the front, and the posterior injuries. So the plan was to do an X-fix and then do SI screws plus or minus an open reduction. And I did have to do a lateral window for him to get the SI joint reduced. I was hoping that by getting the X-fix pins on, I might be able to manipulate it back to where it would belong, but it was very unstable. So I had to open it to get it back, and got into SI screws at S1 and S2. And so these are the rest of his films. And we took him back to the OR, took off his X-fix after about a month, and then went back, I think 4 months later, to take out his SI screws. And this is where he was. At 18 months post-op, he was back to doing his normal stuff and back on his dirt bike without problems. So we're doing okay, or on time. Just a couple studies. Basically, this is a study that showed that pelvic asymmetry does not actually remodel over time. And so it is important that if they do have deformity, that you would consider, resolving that deformity with surgical intervention if they have significant pelvic asymmetry over 1 centimeter. There's very few studies looking at long-term outcomes for these, but any patient who has, these are operatively treated ones with that were treated by adult traumatologists. So there's a couple studies in the adult literature, and adult patients or adult orthopedic traumatologists treated patients. These patients did well in the long term with long follow-up without any complications, returning to full activities. And then this group had anatomic or near anatomic reductions of the unstable pelvic fractures, and they all had normal gait and had no major issues post-op. So those are the only studies really about there, but the conclusions are that most of these fractures can be treated without surgery, but if they're unstable and displaced or open, they do need operative intervention.
Right, fantastic. Thank you for that review. Yeah, very comprehensive. that was a great case example too. Did you put those SI screws with intraoperative guidance?
I actually did not, only because we actually don't have navigation for spine yet. And our, we do have like a hybrid room with the intraop CT, but it was unavailable the day that I needed it.
Yeah. Yeah, with the pediatric pelvises, it's really hard to see the, you know, the landmarks on like the sacral view and to make sure that you're staying out of the foramen. So nice job. That looked great.
Thanks.
All right, Patrick, take us to the finish line with some acetabular fractures, and then we'll discuss some cases.
Sounds good. Sorry.
Oh, did we lose him?
Did he leave? It looks like he left.
All right.
He might have had to change his settings or something. That happened to me a couple times.
Okay.
Wendy, how often do you use Saji? Like, how often do you do that? Because we used to do it all the time. I haven't done it very often anymore.
So I actually hadn't done it since I started here. We'll use him if I'm out of town and we have to send somebody to UC. But actually 2 weeks ago, we had a really bad pelvic ring injury. It was a vertical shear through the with a complete sacral fracture and an APC injury. And so he came over actually to UC or to Children's, and we did the case together because I thought we were going to have to open reduce from behind, and I hadn't done that, I think, since I was a resident. But anyway.
All right, Patrick, you're back.
We can't hear you still.
All right. Can you guys hear me? Good.
Yeah.
Yeah.
Apologies for that. All right. Thanks so much. I did leave Wendy, and I'm sorry. And I did steal her slides. There are a lot of them as well, as well as some slides from Brendan Southam as well too. And so forgive me for sorry, we just technical difficulties today. There we go. All right. So no disclosures. So as you've heard, a lot of the pelvic fractures and certainly acetabular fractures are not very common. They're a little bit more common in skeletal mature patients, high energy injuries, sometimes not. This is a case of Dr. Ramalingam's actually that she was kind enough to loan me. Was a patient who felt a pop when cutting during basketball and had this posterior fracture dislocation. Closed reduced at an outside hospital, and you can see some of the offenders that other people have mentioned so far. These are tough to talk about without talking about hip dislocation, but people who've gone before me have explained those, Dr. Baldwin as well. You know, the 6-hour rule from Chuck Melman, we all talk about the epiphyseal lysis, also a concern, 100% risk in some studies. So making sure you have good sedation and feel good about it. And then ensuring, you know, congruent hip reduction, CT versus MRI. We heard a little bit about as well already. And again, this is just such a common thing with posterior wall fractures being the majority of these acetabular fractures that you can't kind of skirt around them, but they're kind of a constellation. This is that radiographic study, which came out in 2013 from Peter Fabricant, Dan Green, David Helfit, basically showing that, you know, that sort of flex sign that Kevin Klingel talked about can be such a large piece that it can be really deceptive. So anybody that's under 12 and girls or under 14 and boys, we really try to get an MRI, but obviously there's challenges with that. Working towards kind of a rapid MRI protocol can be helpful. Acetabular fractures, Buchholz is kind of the pediatric or young adolescent with still an open triradiate, and then the classic for skeletal mature patients. But those are really kind of shearing or crushing injuries, either a 1-2 or a Salter-Harris 5 injury. Standard treatment, you want to get some skeletal traction if the hip is trying to fall out and it's really dislocated and unstable. These are clear things that are easy. You don't have to stress it or anything. It just kind of keeps slopping out. When they're in traction and stuff like that, if they can't go, or if you're planning on fixing them, you got to think about how quickly the callus develops. So that's a difference with adults. And then the goals are very similar, to adults: restore mechanics of the hip, congruity, stability, and in some cases, alignment of the triradiate cartilage, which is a little bit of a different animal, than adults for sure. And kind of a difficult thing to kind of wrap your head around about how best to go about that sometimes, other than just lining it up. Non-operative treatment, really, is toe touch weight bearing for 6 to 8 weeks until healing is present, and then obviously going to monitor for growth arrest until skeletal maturity. This is an example of where some growth arrest and dysplasia occurred. Indications for operative treatment, really taken from the adult literature without much evidence for it. Articular displacement greater than or equal to 2 millimeters, incongruous hip after reduction of fracture dislocation. And then if you've got incarcerated bone or soft tissue in the hip joint, again, the MRI CT question, a lot of people are going to get CT first and then go back for MRI. Obviously, it's unstable or an open fracture. Similar approaches as the adult. The surgical hip dislocation approach has been mentioned previously. I think it's a really good approach. I think where I've really run into, using this over some of the other things, some of the other approaches, is in some of the young patients, the whole posterior wall, it's not necessarily broken off, but it's like this acetabular deformity where it's actually been almost plastically deformed into the acetabulum inward. And you really have to get that totally exposed circumferentially and actually kind of pry it out and then put it back with some suture anchors or anchors to hold it in place, or maybe a small plate or some absorbable fixation along with the labrum. Some people refer to it as the ring apophysis. So that's why I kind of lean towards that in some instances. Considering smooth K-wires, obviously, for crossing the triradiate. This is going back to that patient of Dr. Ramalingam's. Closed reduction, went on to get a recon plate, looks great. And then obviously checking the femoral head perfusion in the epiphysis with good pulse ox matching. Back to basketball, unfortunately not a dirt bike. 18 months post-op, looks really good. This is another patient actually that Dr. Ramalingam and I did together. As a 14-year-old male, MVC, posterior dislocation, underwent closed reduction, sort of had it all: posterior wall, acetabular fracture, avulsion of the cartilage in the labrum, and then a really bad Pipkin fracture that we were able to kind of put some absorbable fixation in the posterior wall, labral anchors for the labrum, repaired the Pipkin, and then took an Oates from the non-weight bearing portions of the proximal femur to try to patch that defect eventually, and had a good waveform surprisingly at the end of that. So outcomes, really quality of reduction. We heard about hip dislocations in AVN and how that, as part of a posterior wall fracture or acetabular fracture, can be a problem. The triradiate cartilage damage is rare, but may lead to dysplasia. There certainly are growth arrests that are formed there, and I've seen some of those presented with subsequent x-rays showing normal development. Mark Erickson has a couple of those cases from Colorado. So individualized treatment is really necessary. This was an outcome study. These are all Mike Archdeacon's patients before the Wendy came to us and took all those cases back to Cincinnati Children's. And Brendan Southam presented this at AOS in 2018. And sort of the punchline is, we were treating these patients like we treated adults with their indications, but how did they do? And so I'll skip to the sort of punchline. This is the patients, 14 patients, 8 male, 6 female, not a huge series by any means. 3 out of 14 with open physes, 11 to 17 with 5 and 4-year outcome and radiographic follow-up. And overall, they did pretty well and were pretty close to population norms with the exception of the SMFA functional index. There were some major complications: AVN, post-traumatic osteoarthritis, HO, and some sciatic symptoms. There's been lots of studies that have shown similar outcomes in lesser patients for less time. in some cases, but overall pretty satisfactory outcomes with ORAF and sort of adult criteria. But still long-term follow-up and much larger studies are really needed to understand what the right call is for all these patients. So in summary, most acetabular fractures, they can be treated non-operatively, obviously displaced and unstable, similar indications to adults. Patients really need to be monitored for growth arrest, even if you don't see anything. I feel pretty strongly about that for kind of a year without much data to support that strong feeling, to be fair. MRI for those with open triradiate cartilage, less than 12 in girls and 14 in boys, I think is really important. And then just caution when you do those reductions for, reasons that Dr. Baldwin mentioned before. Just want to acknowledge everybody, especially Wendy and Brendan and Mike, as well as my former partners. Thank you.
Nice. Thank you, Patrick. I appreciate it. Really kind of a side question, but that case of the triradiate physeal closure that caused dysplasia, I wanted to pick your guys' brains about creating a bar across the triradiate to treat hip protrusio. What are your thoughts on that? Does it work? How early do you have to do it?
It's an interesting thought. I mean, I think the earlier the better, but most of the time you notice the protrusio, it's farther along, I think, when we see them, but
yeah,
I don't know. It's
yeah,
an
but for
interesting thought.
patients, yeah, that are at high risk, like if they have Marfan's or something. Wendy, Todd, Keith, any thoughts about prophylactically doing a triradiate closure on those patients?
So Beal syndrome, I think, is the actual condition that it was first proposed for by, I want to say it was Steele way back when. And the results that were presented with that were pretty positive. The timing is always the tricky thing, right?
Yeah.
And so I think that's the $1 million question that still hasn't been totally sussed out. But in that scenario, I think if it does certainly makes a lot of sense, and we've all certainly seen the post-traumatic arrest and dysplasia, and it certainly makes sense that if we could iatrogenically create that, we might be able to sort of avoid the devastating challenges of significant protrusio.
Yeah, excellent. Thank you. And Wendy, you had a question, or there was a question from the audience after your talk about using just K-wires for stabilizing an unstable pelvic ring injury. So I know you talked about X-fixes, which is kind of the same concept, but can you stabilize the anterior ring with just K-wires?
I have luckily not had to do that or seen it done in real life. It's talked about. I probably would err on the side of not using smooth K-wires. I imagine they probably, I mean, I'd have to have a really good reason to do it, I guess.
I think it would probably need to be backed up with a cast, and if you're going to immobilize in a cast, I would rather use an external fixator. So I think you're right about that. All right, so we have a few minutes to discuss some cases. We had a similar case that Wendy had presented. This one has a few other complications. So there's a 14-year-old male who presented. He was riding a bike, he got hit by a garbage truck, and unfortunately the truck then ran over him when he was on the ground. So he was a trauma transfer over to our hospital. He had a 3-centimeter laceration over a suprapubic region that was extending kind of from his right AIIS over to the left abdomen. And then the injuries that are shown here. You can see, some contrast placed into the bladder to look for extravasation. Wendy, do you have thoughts? You want to start chatting about this one?
Sure. In the front of the ring, you can see that he's got the left-sided rami fractures. It's hard to tell exactly if the symphysis is lined up where it's supposed to be or not, but the right hemipelvis is superiorly dislocated. Looks like through the SI joint. I don't know if there's any apophyseal ring still attached in the back or iliac apophysis in the back, but certainly concerning.
Nice. So here's the CT, the 3D reconstructions. The CT actually also showed some blush in the inner pelvis. So this patient was actually transferred from our emergency room over to UCSD for interventional radiology intervention for embolization. So just a point to chat about, maybe Keith, Todd, Patrick, you want to talk about, what patients can be managed at a children's hospital, what patients need to be transferred over to an adult center?
Yeah, so we actually we kind of have this like So our adult center will take anybody that's over 14. But we generally have this idea of like, stable patient, like it's basically the patient, either the patient's unstable or stable, and the fracture is either unstable or stable. And you can have kind of mixtures of those things. You know what I mean?
Okay.
Usually if the fracture is stable, the patient's unstable, it's usually not the pelvis,
Okay. Yeah.
But if the fracture is unstable and the patient's unstable, then those will probably relatively rapidly get transferred because our IR people would be probably fairly uncomfortable doing that,
Yeah.
which is strange, but I think they would be. So that would probably be they would probably be transferred. If the fracture was stable and the patient was unstable, they would probably look for something else, and that patient would probably stay. If the fracture was unstable and the patient was stable, it would probably depend on the age. If they were older, then usually Samir or Derek will take those at Penn. So those are our pelvic and acetabular guys. So normally they'll take those at Penn. If they're younger, then oftentimes they will stay at CHOP, and those guys will come over. And if I'm not doing something else, then I'll usually scrub with them and take care of them. And then I'll just take care of the patient afterwards. So it's kind of like those mixture of items, like the age, the stability of the patient, the stability of the fracture.
Yeah. Yeah, perfect. I think it's very institution dependent and kind of your relationship with the trauma team over at the adult facility. Patrick, you want to chat about how you would start to address this? Does it need surgery? Is it stable, unstable?
I would say it needs surgery.
Okay, great.
So obviously you want to get them hemodynamically stable, but then you're going to start to think about, how you would do it. Which before, I left Cincinnati would have been something that we would have basically asked Dr. Ramalingam to answer and probably take over care at this point. But now being somewhere where I have 6 sort of
I
adult,
don't have her anymore. Yeah.
but now I've got six adult traumatologist partners,
Yeah.
in like a sort of smaller children's hospital inside a big one. But I think, same things apply here. To answer your question directly, Salil, is, this looks like it's probably anteriorly disrupted, posteriorly disrupted for sure. And whether it's gonna sit down and sort of talk about this, whether it's gonna need, open or closed treatment in some form or another. And I would probably hand it off from there.
Okay. Yeah. Yeah. So he, with the open fracture, he definitely had to go for a washout. We had that kind of suprapubic incision, fan and steel incision already in place. So he was stabilized from the front with a plate. Whether or not to cross the pubis, maybe Wendy, you want to chime in on that? Is there enough bone to stop short of the pubis? Is it better to get stability across?
I mean, I think in this situation, the entire like superior ramus is obliterated. So in order to get more fixation and more stability, I think it makes sense to go across. Claude Saji would say 2 screws is enough on either side of the fracture. So he would have probably stopped short of the symphysis here.
Okay.
And then I think the skeletal traction is really important for these vertical shear injuries, especially if you're not going to be able to fix them acutely and you're just going to like stabilize them provisionally with an X-fix. You still have to put them on and the skeletal traction on that side. So that's the other important, I think, one of the more important things for this case.
Yep. And then what do you think about the posterior ring here?
I mean, I think it looks okay from where we are. It looks like it's down.
Yeah. So it looked lined up. Yeah, this was done percutaneously in the back. And then we typically get a
Is it
CT.
wide on the left or no?
Yeah, that's right. So kind of an unexpected injury happening on the left side. When you got the right side down and the right ring fixed, the left SI joint kind of started to gap open. So we had a post-op CT scan. Is that pretty typical for the panel as well, getting axial imaging after fixing these? What do you think? Todd is nodding his head. You want to make a comment?
Yeah, ideally, if you can do it in the OR with a 3D O-arm or some sort of spin, that would be best case scenario. So if you identified this intraoperatively, you wouldn't have to go back. But yes, I think axial imaging is required in some form or fashion postoperatively.
Yeah, so this was his post-op CT. You can see, even though, it looked reduced of the views we were using in the OR, it's axially unstable and the left side is opening up. So we took him back 2 days later to do an open reduction of the SI joint, putting a provisional plate to stabilize it, followed by screws. And then you can see from the intra-op image, the one in the middle, when the right SI joint is reduced, the left SI joint widens. So getting the right side stabilized and then percutaneously getting the left side stabilized with one screw. So kind of an unexpected pattern for me at least. Or Wendy, what do you think? Have you seen that type of instability previously?
I mean, honestly, the one we did like 2 weeks ago, it did this in the OR. We got we fixed, it was the right side also. The right side was separated and it was a sacral fracture. But when we put the screw across the sacral fracture, his bone was so, like, we did a transsacral transiliac screw, and his bone was so good that as the screw went across, it actually did kind of widen the SI joint. So we had to modify what we were doing intra-op.
Oh, I see. The screw was going all the way across and it pushed
Yeah,
out.
we did transsacral. And then it pushed it out and it became widened. So then we had to change.
Yeah.
But yes.
So this is the final result, the post-op CT after that correction. All right, and one last case to discuss before we wrap it up. So this was a 13-year-old male who had an e-bike accident. Definitely a separate paper that needs to be done about the hazards of e-bikes. But terrible injury, dislocation, posterior wall fracture, fixed at St. Elsewhere, who came to my clinic 18 months after being fixed with difficulty walking as well as a foot drop. So these are his presenting x-rays now, a year and a half out. Who wants to jump on this one? Keith, you talked about hip fracture dislocations. What would you do here?
I mean, I think, oh,
no, you were good.
Okay. All right, press the wrong button. First of all, I would turn my mute button off, and then I think I think a couple things is like, obviously you need to get some idea of like what's going on with this in a three-dimensional aspect. It looks like the femoral head's kind of sheared off there, which is not super ideal. And then also the other thing that you'd want to know is like sort of what is the time course of the nerve palsy? Was that like right away, or did this sort of happen over time? The reason why I asked this is because one of my friends actually called me up with not a similar problem, but like a guy that developed a delayed nerve palsy, and he ended up having HO from a Coker-Langenbach that was like basically a tube of bone that surrounded the nerve. So not that I'm saying that this is the case here, but it's one of the things that you'd want to know. Yeah, and that looks not great.
Yeah. So interestingly, it was kind of a slow, delayed nerve palsy. And basically, it was unstable fixation of the posterior wall, allowing the head to kind of slowly migrate out. And the implants, as well as the subluxation, has caused the head to get eaten away. And as that wall lifted, the spring plate that was in the back trying to hold that posterior wall down was putting the sciatic nerve on stretch. So obviously this is all in retrospect once we went in there and saw that the nerve was draped over the plate and just really like torn up and beaten. But any reconstructive options, Todd, or what are your thoughts?
With the appearance of that head, I don't think there's anything that is that hip isn't long for this world. And so I think your traumaplasty or arthroplasty partners are going to be your best friends for the sort of deformity that's there in this setting.
Yeah, absolutely. So that's the other kind of lesson, is being friends with your traumatologists, but also being friends with your arthroplasty surgeons, because that was kind of the best option for this patient. We removed all the implants, decompressed the sciatic nerve, did a neurolysis, used the femoral head, left it plastered on the back of the acetabulum, and placed a screw to allow for a good fixation of a cup, and then did the total hip arthroplasty. So this is him 6 weeks post-op, 1 year post-op. His contracture significantly improved and kind of back to childhood function, but obviously got to watch that for the long term. Great. So thanks, everyone. Thanks for participating in this webinar. Really appreciate your time and putting together some excellent talks and your contributions on these cases. So thank you so much. Appreciate it.
Thank you.
Yes, thanks.
Thanks for
Thanks
having me.
all. And I'll just add, as we're wrapping here, we've got another couple webinars coming up soon. Open reduction of the hip in babies, guided growth of the hip, and watch for, we'll post this amongst our other recordings. So there's others there too. So you'll be able to see the past recordings that we've got. And if you haven't already, just sign up and we'll be able to reach out when these things are coming together. So we'll set up the dates and times and reach out soon as these things are getting finalized. But thank you again, Salil. I don't know if there was anything else you wanted to say, but that was very rich and much appreciated.
Yeah, no, that's it. Thanks for helping us put it together, and thanks for all the support from the Hip Hop Network as well as Cortices, the pediatric ortho trauma group. So I appreciate it, everyone.
Excellent. Well, thanks again and good night. And
Good night. Take
good
care.
evening, good morning, wherever you are.